So a little bit about Kerry. So Kerry leads the Method Support Unit at Cochrane and has a background in statistics. She delivers training on common statistical errors and works with the Statistical Methods Group on developing new guidance on the implementation of statistical methods within Cochrane reviews. And as we mentioned briefly before, Kerry's now going to talk to us on different types of systematic review. So welcome, Kerry.
Thank you, Becky. You can see me okay. Thank you very much. So as Becky said, I'm going to talk about how we sort of interpret different types of systematic reviews, and just seeing if I can. There we go. Okay. First of all, I'd like to thank Tianjing and Anna, who are conveners of Cochrane's Multiple Interventions Methods Group, and Rebecca, who's just spoken, for use of some of their slides. To start off, I've got a poll to see if any of you have heard of any of the following type of systematic review, or been involved or conducted any of them. If you could just let me know if you've heard of any of them. Okay, so it looks like qualitative review is the most popular that people have heard of. Rapid review, network meta-analysis, living systematic review, less so on diagnostic test accuracy, overviews, non-randomized studies, prognostic and individual patient data meta-analysis at the bottom there. Okay, that's useful to know. So I'll just run through briefly what some of these are. I'm going to really be focused on network meta-analysis and going through that. So a qualitative review involves including qualitative data, so perhaps free text from a survey, for example, or this could be included in a mixed methods review where quantitative and qualitative data are included as well. A rapid review tends to be a standard intervention review. It's just the methods are slightly reduced, so the review can be done more quickly, perhaps in response to an organisation that need the results quickly. There are a lot of examples of COVID rapid reviews in Cochrane at the moment, and what they might do is they might restrict the search dates, for example, so they only search a short period of time, or they might change some of the methods so that perhaps only one person does data extraction, and this should be transparent within the methods of the review, how they've adapted the methods to make the review done more quickly. Network meta-analysis I'm going to talk more about, but Rebecca already touched on it. It's about combining several different interventions using direct and indirect evidence. And then we have living systematic reviews, which are updated more frequently. So within the review itself, the authors would document how often they would run the search strategy, so perhaps every month or every week, and they would also document when they would update the review. So sometimes the review they search the literature, they identify new studies to be included, they data extract, and then they include the results straight away. Sometimes they will only update the review if the results of some of the outcomes change, but that would be documented in the methods section. A diagnostic test accuracy review. It follows a similar process to the process that Rebecca went through, but it's asking a different type of question. So it's looking to see how accurate particular tests are in diagnoses of particular illnesses. And this would be stated in the inclusion criteria of the review as to which tests the authors are interested in for which particular illnesses. Overviews, they include many systematic reviews of the same, looking at the same topic, and again a similar process is undertaken for overviews. But rather than identifying randomized control trials. The search strategy is looking to identify systematic reviews, and we again identify those and do the data extraction and the quality assessment on the systematic reviews, and there are ways to summarize those. Inclusion of non-randomized studies. So this is more of a different type of study design to include in a standard intervention review. So sometimes RCTs might not be ethical, or none might have been conducted in a particular area. So authors will decide to include non-randomized studies with particular characteristics, so that they can try to summarize the evidence that is available. And again, it's a similar process that's followed, just a different tool. So Rebecca mentioned Robin's Eye, a different tool to do the quality assessment, and different things to consider when data extracting and undertaking analyses as well. And then we also have prognostic reviews. So there's a few different types. And again, this is just about the review question. So you've got average or overall prognosis, and the question you could be asking is, what is the most likely course of this health condition? Or we have prognostic factor reviews, which are what factors are associated with or determine the outcome of a particular health condition. And then we've got prognostic models reviews as well. So are there risk groups who are likely to have a different outcome to others? And again, as with diagnostic test accuracy and standard intervention reviews, it follows the same process that Rebecca's gone through. It's just different tools are used to assess the quality. So for diagnostic test accuracy reviews, you'd be looking at QUADAS-2, for example. And for prognostic models, you'd be looking at PROBAST, and then again, the data that you would extract to include an analysis might be slightly different to standard intervention reviews. And so for diagnostic test accuracy, we have sensitivity and specificity of the test, and these are summarized in a meta-analysis and presented in summary and findings tables, as Rebecca showed. And then we have individual patient data meta-analysis as well. So again, this can be part of a standard intervention review. It's just the methods need to be more detailed to include how the review authors will deal with individual patient data, how they will approach the individual trial authors, how they will store the data, how they will clean the data from the individual trials, and then how that will be combined in a meta-analysis as well, because there's different methods to be able to do that. So, I mean, if anyone's got any questions about the different types of reviews, I'm happy to answer that, but I'm really going to talk through about what a network meta-analysis is and how we can interpret that. So a network meta-analysis is a meta-analysis in the context of a systematic review in which 3 or more treatments have been compared using both direct and indirect evidence from several studies. So why would we use one? Why do we need network meta-analyses? Empirical studies have shown that the most critical question raised by patients and clinicians at the point of care is, what is the treatment of choice for the given condition? You know, someone wouldn't come in to see the doctor and say, can I have treatment A or treatment B? They want to know about all of the different interventions that is available for that particular condition. And so comparative effectiveness research and its quantitative component network meta-analysis have been used now for over a decade to answer this particular question. This is just showing some of the network meta-analyses that are out there. COVID NMA is a project collating all the information on the different interventions for COVID. And then in the Cochrane Library, we have behavioural interventions for smoking cessation, which is an overview and network meta-analysis. And this involves 312 trials with over 250,000 participants included, looking at 845 different study arms. And then we have drugs for preventing post-operative nausea and vomiting in adults after general anaesthesia, a network meta-analysis. This has 585 included studies, almost 100,000 participants, looking at 44 single drugs and 51 drug combinations. And uterotonic agents for preventing postpartum hemorrhage. And this has 196 trials, 135,000 women, looking at 7 different uterotonic agents and placebo or no treatment. So you can see there's a lot of information in these particular reviews. So really it's an extension of systematic review that Rebecca went through, and it's just a statistical component of a standard intervention review. So in standard intervention reviews, we normally have pairwise meta-analysis, so comparing treatment A versus B, but network meta-analysis takes into account many different interventions. And in the literature, it's also referred to as multiple treatment meta-analysis or mixed treatment comparisons as well. So if you see any of these names, it's all referring to the same thing. And this is the most simple form of network meta-analysis. So we've got 3 interventions, A, B, and C. And we've got 1 trial that looks at A versus B, 1 that looks at B versus C. And we've got the indirect evidence from this. And we might also have direct evidence. We might have another trial that compares A versus C as well. And what we can do is we can combine the direct and indirect evidence when appropriate. And this is a more complex network meta-analysis. So the last slide I showed you, there were just 3 interventions, A, B, and C, and we could combine those. And here we have quite a few more. This is the uterotonic agents for preventing postpartum hemorrhage review I mentioned. And this diagram shows the network for the outcome preventing postpartum hemorrhages less than or equal to 500 millilitres. And the circles represent the number of trials and participants that are looking at that particular intervention. And the size of the lines also represent the size of the trials and participants with that direct comparison. So you can see here, it's got the numbers on. So we've got 44 trials, which includes 36,000 participants that are comparing misoprostol and oxytocin. Apologies for the pronunciations. And then we also have different colours as well. So the green is high certainty evidence, the light green is moderate certainty, the yellow is low certainty, and the red is very low certainty evidence as well. So that there's a lot of information just in this one diagram. So going back to what Rebecca was talking about, a good review, this review was published at the end of 2018, so it is a few years old now, so it's not as up to date at the moment as you might hope it to be, but it's not too bad. It was updated to include a large WHO trial, and it included a mix of clinical methods and statistical experts as well, and it was funded by the NIHR. And the search strategy was performed by professional information specialists as documented in the search strategy section. It was published by the Cochrane Pregnancy and Childbirth Group, and it was their information specialists that ran the search strategy. And going back to Rebecca's slide on key quality markers, as I've already said, the network meta-analysis follows the same key stages as a standard intervention review, and also has the same key quality markers as a standard intervention review. There are just maybe a few other additional things that we'd like to consider. We'd still want to see a pre-published protocol, make sure that's available. We want the question to be well defined, but with a network meta-analysis, it's important that the authors have justified why a network meta-analysis is actually needed. it could be because there's a lack of head-to-head comparisons between different comparisons, or there's lots of independent comparisons as well. It's important that the inclusion and exclusion criteria is very clear. Thinking about the transitivity assumption, which I'll go on to talk about next. And it's important that the authors explain how they've selected the interventions. I think someone asked before about, you know, what would it depend on what you find as well. So the authors would need to deal with that in the protocol and say that these are the interventions they're expecting to find and want to include. And if new interventions come up in the future or identified in the search strategy, they would say how they would deal with those as well. A comprehensive search strategy, again, this would be similar to a standard intervention review. It just may include a lot more interventions in the search strategy. Again, it's important in all types of reviews, not just for network meta-analysis, but for diagnostic, test accuracy and prognostic as well, and the rest, that there's dual study selection, data extraction and risk of bias assessment. The risk of bias assessment for network meta-analysis is the same as for a standard intervention review. So we would be recommending the risk of bias 1 or 2 tool for Cochrane. And then it's important that the study characteristics are well defined, and there's appropriate data analysis and presentation of the results. And this is really important, as I'll go on to show, because as you can imagine, with so many more interventions included in network meta-analysis, there's a lot more data. So the presentation of the results can be a lot more difficult, and it's obviously important to make them as clear and as accessible as possible. And again, the conclusions based on should be based on the review findings. And again, it's important to involve clinical experts here, because again, you've got a lot of data from the network meta-analyses, and it's important to be able to summarise that succinctly. And again, minimal and well-justified protocol deviations. So if there's any changes from the protocol, these should be specified and justified as well. And as Rebecca said, there is a section within Cochrane reviews that's titled Differences Between Protocol and Review section to make sure people do just that. And there's also an extension to the PRISMA statement. So that was published in 2015, and that goes through what should be reported for a network meta-analysis. So the transitivity assumption is it's just an extension of that for pairwise meta-analysis. So it's just making sure that the interventions are similar, so that if you have one trial that's comparing treatment A versus B and another that's comparing treatment A versus C, we want to make sure that treatment A in both are similar enough that it makes sense that they can be combined. So one example I have is for dietary advice. So in the trial A versus B, people for treatment A go to see a dietitian once a week, and treatment B is going to see the doctor. Whereas in the trial A versus C, treatment A is going to see a dietitian once a month, and intervention C is going to see the nurse. So you'd need to decide really, well, actually going to see a dietitian once a week or once a month, that is quite different. So it might, the assumption might be violated. So it's just making sure that in general, the studies are similar in that participants could be randomized to any of these particular treatments. And another important consideration, again, it's just an extension as with pairwise meta-analysis, is that the trials are similar in terms of characteristics as well. So for this top one, placebo versus B, participants tend to range between 20 and 50. And again, it's similar for placebo versus C. So it'd be okay to combine these in a network meta-analysis. However, in the bottom row, you can see that actually placebo versus B, that the participants are quite a lot younger than those in placebo versus C. So it might not make sense to combine these in a network meta-analysis. So it's just important that when you're reading through a network meta-analysis that the authors have taken this into account, so that actually the results of the network meta-analysis make sense and are not misleading. So we want to make sure that the treatments that are being compared are jointly randomizable. The groups don't really differ with respect to the distribution of effect modifiers, such as age, as I've just shown in the last slide, and that the direct and indirect treatment effects are in statistical agreement. So this is known as coherence in network meta-analysis, and it's just another method that we make sure that authors have taken into account when undertaking the network meta-analysis. And in Cochrane, we have the Cochrane Method Support Unit, which I'm lead of, and we tend to look at all, or we do ask to look at all network meta-analyses that go through Cochrane now, so that we can make sure that the authors have taken these methods and other issues with network meta-analysis into consideration. So what can network meta-analysis achieve? So here it shows a forest plot of the relative effect estimates. So you can see it's quite a lot more detailed than you perhaps see in a standard pairwise meta-analysis. You have the different comparisons. So here we've got oxytocin versus placebo or no treatment, and we're given the direct evidence, the indirect evidence, and the result that combines both of these for the network meta-analysis as well. And on the right hand side, it gives you the risk ratio and the confidence interval. And it does that for each of the different comparisons for each outcome. So you could get one of these graphs for each outcome. And another way of presenting the data is in a league table. So you might see this when you're reading through a network meta-analysis. And this isn't from the same Nutritomics review, it's from a different review because there's no hard and fast rules as to how authors should present the data. There are just different ways. So down the diagonal line, we've got the different interventions. So here we've got Adjen and Amit, I think. So it's difficult to read on. A bit bigger. And in the bottom left-hand corner, these are all the results from the network meta-analysis. So these are combining the direct and indirect evidence. So you've got your effect estimate of 0.96 and the confidence interval. So here from 0.76 to 1.24. So that's the results from the network meta-analysis. And then the top right-hand corner in the yellow colour, they are the results from the direct evidence only. So all of the trials that have directly compared these different interventions. So if you wanted to look at FLOV versus AGOM, you'd go up here and you would look and you see the results for AGOM versus FLOV is 0.69 and the confidence interval is given there as well. So you can see and this is only for one outcome, so you can see there is a lot of data there, and the more trials and the more interventions that you include, obviously the more data that you will obtain. Something else that an NMA can give us is treatment ranking. So, you know, it's really important to know the relative effect estimates, and that is the most important thing. But there are methods that can rank the interventions as well, so we can find out what's best and what's worst. But this might differ by outcome as well. So, you know, you would need to consider other outcomes as well and not just look at it by outcome alone. And the findings for this review, again, it's quite complex because of the amount of data that those forest plots I showed you, that was just for one outcome. So it's really important to involve the clinical experts to help interpret the data in terms of what's important for the reader. And this is just some information that I've taken from the abstract. The relative effects from the network meta-analysis suggest that all agents were effective for preventing postpartum hemorrhage, greater than or equal to 500 millilitres when compared with placebo or no treatment, and the effect estimates were given in the abstract. And then it talks about ranking the 3 highest ranked uterotonic agents for prevention of PPH, and it lists those as well. I'm not going to try and pronounce them. And then misoprostol plus oxytocin reduces the use of additional uterotonics, and it gives us the risk ratio and confidence interval, and tells us that it's high certainty evidence, and probably also reduces the risk of blood transfusion as well. The 2 combination regimens were associated with important side effects, so it's important to take into account all the different outcomes when summarising the evidence. And then going on to the quality assessment, again, it's similar as for a standard intervention review, as I've said, and we've got the risk of bias table that's presented, and this is presented using risk of bias 1, so it's by study, and it lists all of the studies and the domains, and you can see there's a variety there of low risk of bias, unclear is yellow, and then red is high risk of bias. So there's a lot of unclear there, really. And this is taken into account in the summary of findings table. And you can see it's similar to what Rebecca presented. However, the difference for network meta-analysis is that the summary of findings table tend to be by outcome, rather than in a standard intervention review, they're by comparison and include all of the different outcomes in one table. But here we do it by outcome. So here we've got postpartum hemorrhage, and then it lists all of the different treatments in the rows, and it gives us the direct evidence, indirect, and the evidence from network meta-analysis. It gives us the certainty of the evidence, which is taking into account the risk of bias along with other factors, and it gives us absolute effects as well. And all the information is at the top about the patient population, the different interventions, the comparator intervention with oxytocin, the outcome and the setting as well. One thing to mention here is that grade was used on this particular review to assess the certainty of the evidence. However, there is another method called cinema, which can be used for network meta-analysis as well. So as long as either of those 2 are mentioned in the review, that's fine. And then just showing you that that it was actually included in WHO recommendations, this review as well. So, you know, it is highly influential. And then just going back to Rebecca's slide about a good review, no matter the type of review, whether it's includes network meta-analysis, whether it's diagnostic text accuracy, whether it's a prognostic review, they should all follow a pre-published protocol. And with Cochrane, these are published on the Cochrane Library. It should report the methods transparently. Again, they will all differ. The different types of reviews differ in the types of methods used, the quality tools used, the reporting checklists used, and even the analysis, different types of data that's included, but they should all be reported transparently, and the quality assessments should be done for each of these different types of reviews. Presenting the findings accessibly, as you can see with that network meta-analysis I've just gone through, it is quite difficult to summarise so much information in a succinct way to make it readable for patients and clinicians, because there is a lot of information there, and it's important to base the conclusions on the review findings. And as Rebecca said again, a review is only as good as the studies included. So if all of the studies are unclear or high risk of bias, this should be reflected in the grade ratings. So should be summarised in the summary of findings tables and in the abstract as to how certain you are about the quality of the evidence. That's it from me.
Great. Thank you very much for that, Kerry. yeah, I mean, network meta-analysis is something that I'm only just starting to try and get my head around. I think every time I see one, I have to go back and have a look at what's being done, how's it being analysed, to draw the right conclusions, because like you say, they do contain an awful lot of data in them. So in terms of the Q&A, we've got a few things coming up, and if you want to add anything else, please use the Q&A box rather than the chat box. So the first question is about what's the difference between a scoping review and a rapid review?
The scoping review is really looking to see what literature is out there about for a particular question, to see perhaps what methods should be used, perhaps to looking to see if there's randomized controlled trials or observational studies available for which particular interventions, so that people can then go on to, it'll just help people define their review question better, and the methods that are needed for that particular review question. Whereas a rapid review is, the review question, the types of studies you want to include. It's just, the rapid review tends to be needed quicker, perhaps, as I said, to be included in guidelines that are going out, or to inform. It tends to be people such as the WHO who would ask for a review to be done rapidly. So then people would edit their methods to make sure the review is done more quickly. So as I said before, they might just search a shorter period of time rather than an open-ended period of time, or one person might do the data extraction. There is a methods group for rapid reviews in Cochrane, and they have recently published guidance on what people should do with a rapid review, which methods are more appropriate to change and which aren't. And as with all of the different types, prognostic, diagnostic test accuracy, qualitative, non-randomized studies, there tends to be a Cochrane methods group for all of these different methods that produce their own guidance, or their own the DTA group are publishing a handbook on diagnostic test accuracy soon. I'm not sure on the exact date, and they've got their own guidance on their websites, and tutorials. And again, the Cochrane learning team have different modules. The modules tend to be you have to pay for unless you have a Cochrane account, but there are free webinars are available on the Cochrane website as well, such as we did a Learning Live. Sorry, I'm going completely off topic here, but we did a Learning Live series on network meta-analysis, not last year, the year before, and we had, and they're all available free on Cochrane training.
That's great, thank you. Next question is, should a network meta-analysis method be stated a priori, or if planning a standard systematic review and meta-analysis, could you then kind of change your protocol and do a network meta-analysis if you had enough studies or it was appropriate?
We do say it's best, but you should plan it in advance, because there are issues to consider, and the Comparing Multiple Interventions Methods group do recommend that a knowledgeable statistician is included on the author team as well, because it's not, you can't undertake a network meta-analysis in the RevMan software that Cochrane uses. It has to be done in other statistical software, so it's not something that that a lot of non-statisticians can do. Yeah. But yeah, it's important to define things in advance, and the methods, because there are different methods you can use as well. So there are things you need to take into consideration.
Yeah, and I think conversely, even if you plan an NMA but find actually it's not appropriate, you can switch to a standard.
Yeah, I mean, some authors in their protocol say they're going to undertake pairwise meta-analysis and network meta-analysis. And then obviously they maybe can't perform the network meta-analysis because perhaps the assumptions that I talked about aren't met. So that's fine. They just say that that's what they've done, state it in the differences between protocol and review section. But again, if you undertake the review and you find that actually this could be appropriate for network meta-analysis, it's more suitable to then write another protocol once you've completed that.
Yeah, that's great, that's helpful. We've got a question about kind of certainty of evidence, and I don't know if that's just relating to, maybe just expand a little bit more on grade and how it's used.
Yeah, so there's two methods that can be used for assessing the certainty of evidence for network meta-analysis, and one is cinema and one is grade. And it takes into account the risk of bias, publication bias, the consistency in the estimates. It's basically, it's very similar to what you would do for standard intervention reviews for pairwise meta-analysis. It just takes into account the indirect evidence as well as the direct evidence, and cinema and grade differ slightly, but they're both available for people to use and both recommended in the Cochrane handbook.
Yeah, great, thank you. So I'm just having a look at the other questions. So if it was mentioned in the protocol that they're going to include randomised controlled trials, but when they were unable to find any, can non-randomised trials then be included?
Again, it really should be stated a priori. It should be, you should justify the inclusion of non-randomised trials. As Rebecca said, Cochrane do publish empty reviews, so it may be the author has undertaken the review and not found any RCTs, and one of the recommendations is for a further review on reviews with non-RCTs. I mean, it really depends on the topic area, but we wouldn't recommend that you publish the protocol to only include RCTs and then completely change, because there are other issues to consider, different quality tools, adjusted estimates, and like different analyses for non-randomised studies. So there's just a bit more to think about. So
I think that's sometimes where a bit of scoping beforehand can come in useful, or at least being aware of what your
so I mean,
is.
A lot of the time, if a clinical expert in a particular area will be aware of what's available as well, so they'll be able to inform if non-RCTs are appropriate or not.
Great. And then the next question is, are the relative risks in the slide of the forest plot comparing two treatments to each other, or one treatment compared to placebo?
There were lots of different comparisons. So the first one was oxytocin versus placebo, and then I can just get my slides up and oh, you've got that, great. Yeah, so you can see that. So the first few are comparing the different interventions to placebo or no treatment, and you get halfway down, and then you've got one treatment plus oxytocin versus oxytocin, and then sorry, it's quite small, so it's difficult to say, carb something versus oxytocin. So it's showing all of the different treatment comparisons. And as I showed in the league table as well, you've got all of the interventions included in the diagonal. So you've actually got all of the different comparisons in that league table as well. So it just depends how the authors have presented it. And, as a reader, you just want to make sure that they've actually included all of the different interventions on that forest plot or in that league table. And again, going back to the network diagram, that should be done for each outcome, because the network might differ for each outcome, because not all trials would report every outcome. So it might be that some interventions are included for some outcomes and not others, because those trials haven't reported it.
Great, thank you. And then this is getting a bit more technical. So are there instances where Bayesian NMA may be preferred rather than an NMA? And are there concerns about Bayesian network meta-analysis introducing even more indirect methods to indirect comparisons?
I can't think off the top of my head when it'd be preferred. I think it's just different statisticians' preferences into using frequentist or Bayesian approaches. They can both be done in standard software now, and the Complex Review Support Unit has actually produced apps that people can undertake the analyses in as well. So I think as long as the authors are clear in their data synthesis section which approach they're using. For Bayesian network meta-analysis, you tend to need to specify, pre-specify more things, such as the prior distributions used, the iterations used in the analysis, that type of thing. So as long as that's done, it doesn't really matter which approach they use. Cochrane doesn't have, I mean, in Cochrane especially, we don't have a preferred approach.
Thank you. I'm going to butt in now with a question of my own, but are there kind of things in development in terms of new kind of review types or new review designs in the process, I suppose, in the pipeline? Yeah, because like compared to when I went through med school, network meta-analysis didn't really exist, or the diagnostic test accuracy studies. I suppose I'm wondering if there's things in the pipeline or things that are being looked into as kind of new types of systematic review at the moment.
I think there's just extensions. So I think that I might be wrong, but I'm sure there's a like network meta-analysis for diagnostic test accuracy studies now as well. So taking into consideration lots of different tests in the analysis as well. At the moment within Cochrane, we're focusing on complex interventions and methods for public health as a result of COVID. So that's what we're focusing on in the methods team in Cochrane. As for other types of systematic reviews, I'm sure there may be, but I mean, these are the main ones that I'm aware of. The ones that I spoke about at the beginning.
Yeah, great, thank you. And then there's another question, which is for the network meta-analysis, is the results that looks like a forest plot still called a forest plot, or has it got a different name?
Yeah, the forest plot is still called a forest plot. It's just that, I mean, every network meta-analysis can show it differently. On this one I showed you, they've showed the direct evidence, the indirect, and the network meta-analysis estimate for each comparison. But some may just show the effect from the network meta-analysis. It really depends. I think it asks about the table as well. The table's called a league, tends to be called a league table, and that just has the results in for all of the different comparisons. And it's showing what's in the forest plot as well. It just didn't have the indirect comparisons in the league table as well.
Lovely, that's great. That's really helpful, Kerry. So thank you for your time and giving a really interesting talk.